Anyway, we're going to go ahead and get started with the basic science session. My name is Kasper Wang. I'm one of your moderators.
And my name is Samir Pandya. I'm the other moderator.
Thank you. Thanks for coming to join us. So we're going to push ahead here right now.
And so we'll start with our first presenter. This is Dr. Frederik Buch from Mainz, Germany, discussing access to an online video enhances the consent process, increases knowledge, and decreases anxiety of caregivers with children scheduled for inguinal hernia repair, a randomized controlled trial. That's Dr. Buch.
Hello, my name is Frederik Buch and I'm from the pediatric surgery in Mainz in Germany. And I'd like to present our study, Access to an Online Video Enhances the Consent Process, Increases Knowledge and Decreases Anxiety of Caregivers with Children Scheduled for Inguinal Hernia Repair, a randomized controlled study. At first, I'd like to mention that there is no conflict of interest and our study was approved by the state ethic boards. Obtaining well-informed consent is essential in pediatric surgery. However, there is limited time in daily clinical practice. Also, the situation of just being informed that their child needs to undergo an operation may limit the capacity to understand everything that is said during the verbal informed consent process. Our study evaluates whether supplemental ad-lib access to an online video of the consent dialogue enhances the consent process for inguinal hernia repair in children. Therefore, we produced a 6-minute video of a consent dialogue on inguinal hernia repair and uploaded it on an online platform, YouTube. The video was not available for people other than the participants randomized into the intervention study group. For this purpose, we created a specific link leading to the video. In the video, Professor Münsterer, who is the head of pediatric surgery in Mainz, you can see him right here, explains the condition, procedure, possible complications, and postoperative expectations of inguinal hernia repair in children. The endpoints, anxiety, knowledge, and satisfaction were measured by validated and partly modified questionnaires. Families with children scheduled for inguinal hernia repair were offered to participate. After consenting, the parents were randomized to the control group with conventional face-to-face consenting or the intervention group with ad-lib access to the video anytime after the clinic visit. During their child's surgery, the caregivers were asked to complete different questionnaires. The State Trait Anxiety Inventory as well-validated questionnaire was used to measure the parents' anxiety level. To measure knowledge about inguinal hernia repair and the satisfaction with overall care, validated questionnaires were modified to fit our study collective. The anxiety measured with the validated STAI questionnaire was significantly lower in the video group. Also, the knowledge about inguinal hernia repair was higher in the intervention video group. There was no difference in satisfaction with overall care between both groups. In conclusion, preoperatively providing caregivers access to an online video regarding pediatric inguinal hernia repair reduces anxiety and enhances knowledge without altering their satisfaction level with overall care. Adjunct online videos are a useful tool to enhance the consent process. The production of the video required a relatively low financial budget. So we plan to produce more videos for other procedures in different languages in the future. Thank you very much for your attention. I'm pleased to answer your questions.
This paper is for discussion. Dr. Buch, this was very interesting. I have a couple of questions for you. I can see how this can facilitate the consent-taking process for families, and I could see how you could standardize that discussion. including figures and pictures. But in your study, did you come across any instances in which the parents got confused before they came to you, or they had some additional questions that you didn't think that they would have? And the follow-up to that also is, do you think that you would use this only for low-risk procedures, or would you extend it to more complex procedures like colectomies?
Thank you very much for your question. You're right, the principle of multimedia enhancement of the consent process has tremendous potential. In the future, we may program interactive apps for specific procedures with figures, graphs, and videos. At this time, we are still working on producing basic video as seen in our study for basic procedures like the inguinal hernia repair. We really never perceived any confusion in the parents from watching the video, but also we kept the presentation very structured and basic. Also, the parents had the opportunity to watch the video as often as they wanted to, and as it was necessary. Concerning the more complex operations, standardized video can probably be used, but they should be supplemented by a conversation in person to make sure that all aspects of the individual case are covered. Thank you.
Thank you.
All right, the next talk is entitled Cellular Trafficking Across the Blood-Brain Barrier Following In Utero Hematopoietic Cellular Transplantation, to be presented by Dr. Grant from WashU.
Thank you. We have no disclosures. Fetal surgery, although a relatively young field, has been quick to progress. Initially, it started as open fetal surgery and has moved into fetoscopic and minimally invasive techniques. And the future of the field is headed toward even less invasive things such as cellular therapy and gene therapy. Among these modalities is a procedure called in utero hematopoietic cellular transplantation, or IUHCT. This technique utilizes a unique time period in immune development in which the fetal thymus is still undergoing education. So transplantation occurs during that point. Donor antigens are presented to the recipient thymus and presumed to be self. This allows for central and peripheral tolerance without the need for myeloablation. It has the potential to treat a multitude of genetic diseases, and among those include a subset of neurogenetic diseases, lysosomal storage disorders. These diseases, although individually rare, as a family constitute about 1 in 5,000 live births. They have devastating effects across multiple organ systems, but most prominently in the neurologic system. There's currently no cure, but several of these patients are palliated postnatally with a bone marrow transplant, which led us to investigate whether this treatment or whether this disease may benefit from treatment with an in utero transplantation. Thus, we hypothesized that the immature blood-brain barrier present during early to mid-gestation would allow for trafficking of donor-derived cells into the CNS of a recipient. We investigated this by performing an intravascular IUHCT in a murine model during gestational ages E13 to E16. We injected 20 million donor-derived cells donor cells into each fetus, and then evaluated those mice postnatally at months 1, 3, and 9 months by looking at their brains with fluorescent microscopy, immunohistochemistry, as well as a volumetric analysis. This is accomplished technically by first performing a maternal laparotomy and then injecting a B6 GFP mononuclear bone marrow cells into a BALB-C fetus by means of the vitelline vein, which you can see here in this picture. This is a previously well-described model that allows for tracking of that green fluorescent protein and has been reliable in engrafting into hematopoietic niches. However, there's limited, if any, evidence as to where these cells go within the CNS. So our results yielded mice that were ranged from 8.6 to 88% chimeric, with donor-derived cells present in the CNS of every specimen analyzed at every single time point, with those cells most concentrated in the cerebellum, which you can see here. The cerebella of 3 mice ranged E13 to E15. Qualitatively, you see a similar distribution of those positive GFP cells. Another E13 mouse investigated 3 months postnatally. You see this wide distribution of GFP positive cells and a higher magnification on the picture to your right at 150x. You begin to almost see a cellular neuronal type morphology. That certainly was the case histologically, as we sectioned those specimens and stained them with GFP immunoperoxidase, or DAB staining. So anything that shows up dark on these slides is positive for GFP. In sections A and B, you see Purkinje cells, or cerebellar neurons, and then in sections C and D, you begin to see other CNS morphologies, such as microglia and astrocytes. In section E, you see donor-derived undifferentiated cells, which were the most commonly observed cellular subtype in all the specimens analyzed. And in section F, you see a very intensely GFP-positive meninges with a similar distribution seen within the perivascular spaces. Within the cortex, you see donor-derived cells beginning to form this complex lattice of interconnected interneurons. And in order to quantify this, we analyzed these brains with a volumetric analysis performed with a software called Stereo Investigator, which allowed us to normalize the number of GFP-positive cells per standard unit of volume. There are donor-derived cells within the brain at all time points with a preference towards the hindbrain. However, this was not statistically significant. In conclusion, the blood-brain barrier is permeable enough during early to mid-gestation to allow for CNS trafficking from donor cells into recipient CNS as a result of IV-IUHCT. Those cells seem to home toward the cerebellum, likely as the hindbrain's later embryologic development compared to the forebrain. And hopefully this shows you that this serves a proof in principle model for the treatment of lysosomal storage diseases with IV-IUHCT. I'd like to thank CDI for funding this project, as well as my mentor, Dr. Vresenak, and the PSDL lab for assisting in histologic analysis. Take any questions.
Questions from the audience? If you state your name and where you're from.
Yeah, Decope, London. Thank you for your interesting study. Could you elaborate a bit why you use a black cyst on a bulb C? I mean, in utero, allogeneic transplantation showed to reject. Is that because the brain doesn't get rejected, or?
So for translational reasons, we opted to use what would be more of a haploidentical model. The idea being clinically, we would use mom as the bone marrow source for a transplant into fetus. This is the best way to mimic that in an animal model rather than doing an identical type transplantation with a B6 GFP into a B6 fetus.
Thank you.
I have another question.
Yes.
So in terms of validating that the transplanted cells actually become other things. Mm-hmm. Certainly the morphology is supportive of that notion, but not definitive. So are there ways that you can further validate that the transplanted cells are actually becoming neuronal subphenotypes of different types?
Yes.
Be it co-staining for specific markers? Are there functional tests that you can do to prove that they're actually doing what they're supposed to do? Or are they just sort of bystanders that are just sitting there extra and not really doing anything?
The short answer is it's not necessary. Talking to our histologists, they believe this looks like a duck, it talks like a duck, it is a duck. The way to prove that definitively is that you can stain for other neurotransmitters. These Purkinje cells are GABAergic, so you can stain for GABA neurotransmitters within them to show that they would behave and excite like a neuron ought to. And then the kind of gold standard way to do that is to then laser excise that neuron and actually have it on a thin slice and excite it and see that it truly does behave as that.
Okay, and another interesting question that came across my mind watching your talk is, so the blood-brain barrier eventually becomes impermeable, although it seems as though as the embryo gets older, it becomes more permeable or more accessible. Is that right? That it's certainly hindgut more than foregut, but it looked like at the later stages of embryonic development, there was more cells counted or implanted.
Yes. And
Can you explain that?
In our data, it was not statistically significant. It's just, I think we need more power. We need more, but the exciting part is they were present in each brain at every single time point.
All right, great, thank you.
Our next paper is presented by Dr. Riccardi from Yale, New Haven, and it's entitled Systemic Fetal Gene Editing as a Treatment for Cystic Fibrosis. Dr. Riccardi.
Good afternoon. My name is Adele Ricciardi, and I'm an MD PhD student at Yale University. It's my pleasure today to tell you about some of our work on correcting CFTR mutations prior to birth as a treatment for cystic fibrosis. I have one disclosure. There is a growing consensus that early treatment of cystic fibrosis is crucial in preventing or delaying permanent organ damage. Even at birth, there are signs of multi-organ disease, which is evidenced by the prevalence of neonatal exocrine pancreatic insufficiency, reduced birth weight, meconium ileus, tracheomalacia, biliary cirrhosis, and the absence of the vas deferens. We hypothesized that early intervention through in utero gene editing could correct CFTR mutations during the initial stages of disease pathogenesis. And this could potentially allow for normal organ development, functional disease improvement, or perhaps cure. We achieve non-enzymatic site-specific gene editing by using a peptide nucleic acid, or PNA. A PNA is similar to DNA in that it has a specific base sequence. Rather than a phosphodiester backbone of DNA, however, a PNA has a modified polyamide backbone. This backbone confers stability as well as resistance to nucleases. When introduced into a cell, a PNA is designed to bind either upstream or downstream of a mutation of interest. This forms a PNA, DNA, PNA triplex structure. The cell recognizes this helical distortion as aberrant and will remove the surrounding DNA. We can also introduce a short, single-stranded donor DNA that contains the base pairs that we would like to introduce. The cell can then use this as a template for homologous recombination, resulting in a specific in situ gene change. Peptide nucleic acids are hydrophobic and not readily taken up into cells, so we can formulate them into biodegradable nanoparticles using a technique called double emulsion solvent evaporation. This results in spherical nanoparticles that you can see in the scanning electron micrograph on the right that we can use for in vivo delivery. Clinically, maternal fetal medicine specialists as well as pediatric surgeons can deliver therapies in utero to the umbilical vein under ultrasound guidance. Again, we use a very similar technique in lab where we perform a midline laparotomy excision on a mouse of a known gestational age to expose the uterine horn. On the right, you can see a fetus on the 15th day of gestation. You can make out the anatomy as well as the vitelline vein, which is part of the extraembryonic circulation. We can cannulate the umbilical vein using a glass pipette under a microscope. We were first interested in asking where our nanoparticles go in utero, so we delivered fluorescent nanoparticles. And here you can see the fluorescent nanoparticles entering the vitelline vein. After 3 hours, we assess the distribution of the nanoparticles, and we see very widespread distribution after intravenous delivery on both the 15th and 16th day of gestation. When we look at individual organs, again, we see widespread delivery with particles accumulating in the lung, liver, and gut, some tissues affected by cystic fibrosis mutations. We next wanted to see if PNA and DNA nanoparticles could be used to correct the most common cystic fibrosis mutation, F508del. So we delivered the nanoparticles intravenously on the 15th day of gestation and then measured for functional CFTR activity postnatally. The first assay that we looked at was the nasal potential difference. This is an in vivo measurement of CFTR activity in the nasal epithelial cells. 4 months after a single in utero nanoparticle treatment, we found a decrease in the nasal potential to a level that was similar to that of the wild-type mice, indicating sustained CFTR activity in these mice. We also looked at the rectal potential difference and again found improved chloride flux in the rectal tissue 8 months after fetal treatment. We also collected the bronchoalveolar lavage fluid and assessed for the cellularity, an indication of inflammation in the lung. And we found a decrease in inflammation in the lung 8 months after a single fetal treatment. And lastly, we looked at editing in some tissues that were relevant for cystic fibrosis. Here is some droplet digital PCR data looking at editing in the lung, gut, and pancreas, where we see clinically relevant levels of editing in these tissues affected by cystic fibrosis. So in conclusion, I showed that nanoparticles can be delivered in utero to tissues affected by cystic fibrosis mutations, and that PNA and DNA nanoparticles can be used to correct CFTR mutations before birth, and this results in sustained chloride flux in multiple tissues in vivo and a decrease in inflammation in the lung. I would like to thank my many mentors at Yale, as well as the members of their labs that help with this work. Thank you.
Questions?
Hi, I'm Joe Davidson from Great Ormond Street Institute of Child Health in London. Do you have any idea about any potential off-target effects or other sites of action of your PNA?
Yes, thank you for that question. So the technology that we're using is free of a nuclease, meaning that we're not introducing any single or double-stranded breaks into the genome. We have looked for off-target effects in multiple mouse models, multiple fetal mouse models, as well as adult mouse models, and have yet to find off-target mutations at the site of PNA binding of our donor DNA, or of sites that are similar to that of our PNA, which are the sites that we would think would be most likely to find an off-target mutation.
Drucy Borowitz from Buffalo. Was this a knockout F508del mouse or a knock-in? And if it was knock-in, did you see any immunogenicity of your...
Yeah, so this mouse has the delta F mutation, the most common CF mutation, and we do not see any immunogenicity of our nanoparticles or PNA. So we looked at multiple cytokines and did not see any elevation in any of those.
Really incredibly important observation. Thanks.
Yes, thank you.
Any more questions?
I have one question. So I'm just a pediatric surgeon. Everything was really beautiful. Did the mice that were treated have a vas deferens?
So this mouse model, the CF homozygotes do have a vas deferens, so it's not a good model to look at that.
If you could show pediatric surgeons that this treatment allows the vas to develop normally, it would be something we all could just see and visualize.
I think the ferret model has absence of the vas deferens, and I think that would be a good thing to look at in that model. Thank you.
A quick question. You showed a more dramatic effect in the nasal mucosa relative to the rectal mucosa. So is that is there more integration into nasal directed or downstream derived tissues, or is it rather sort of a dose response effect where maybe there was more corrected gene correction in the nasal tissue rather than the rectum, and maybe the rectum was more of a mosaic of sorts, or whatever? Do you have that degree of resolution to be able to figure that out?
I don't think I have that degree of resolution yet. We could definitely look at higher doses of the nanoparticles that we're using. The nanoparticles also distribute to different tissues in utero. We're using very basic biodegradable polylactic glycolic acid particles. That's a polymer that's FDA approved. We know that we can use different particles for our treatment as well, and that these particles have different tendencies to go to different tissues and different cell types. So that's something that we could address by using a different particle.
All right.
All right. Thank you.
Thank you.
All right. The next abstract to be presented is entitled In Utero Liver-Directed Lentiviral Gene Therapy Cures a Pig Model of Hereditary Tyrosinemia Type 1. And this will be presented by Dr. Nicholas.
Thank you. Good afternoon. I'm going to be talking about the work that we've been doing in Dr. Lilligard's lab towards cure of HT1, hereditary tyrosinemia type 1, in a pig model through in utero gene therapy. I have no disclosures. So HT1 is an inborn error of metabolism caused by a deficiency in the FAH enzyme of tyrosine metabolism that causes an accumulation of toxic metabolites in the liver, ultimately leading to cirrhosis and HCC. The current standard of care for HT1 is a drug called NTBC, which blocks the tyrosine metabolism pathway upstream of the metabolic defect, essentially converting HT1 into the more benign HT3 phenotype. But NTBC is far from a perfect drug. It's a chronic, lifelong treatment with the resulting compliance issues, and these patients develop significant progressive neurocognitive impairment while on the drug, and long-term, they still develop fibrosis and HCC. All this means that they require very close monitoring throughout their entire lives, and additionally, 10% of patients will be refractory to the drug. So gene therapy offers a potentially curative alternative to NTBC treatment, but why do in utero gene therapy? So in HT1, the corrected FAH-positive hepatocytes have a natural selective advantage over the FAH-negative cells so that they can expand in vivo to repopulate the liver. So by curing or by treating the disease in the womb, we hope to take advantage of the rapid expansion of fetal hepatocytes as well as of this immune-privileged environment to make our therapy more efficient, as I'll show you later. We also hope to minimize the organ damage that we now know occurs early in life and despite appropriate treatment in these patients, as well as minimize NTBC's side effects. So these experiments were performed in FAH knockout pigs created by disruption of exon 5 of FAH, and NTBC was administered to these animals, both to expecting mothers and nursing piglets, and was discontinued at the time of weaning in both treated and control pigs. The pigs were then put back on NTBC for 7 days if weight loss occurred. In utero injections were performed around day 70 of gestation directly into the fetal hepatic parenchyma, and then these animals were delivered by C-section at term. So we show here a schematic representation of our lentiviral vector, where we deliver the human FAH gene under control of hepatic-specific alpha-1 antitrypsin promoter. On the bottom, you can see the piglets that we treated. I'm going to focus on those pigs that are highlighted in the red box. These are 4 mid and long-term animals that were cured. 2 of them, as you can see, required no cycles on NTBC, which means that essentially, as I'll show you, they were cured of their disease from a clinical standpoint at time 0. So just to give you a little bit of background, when we started doing gene therapy for HT1 through the ex vivo approach, we required between 100 and 150 days post-treatment of cycling on and off NTBC to achieve cure. When we moved on to in vivo gene therapy, this time was shortened to 70 to 90 days post-treatment and an average of 4 cycles on NTBC to achieve clinical cure or NTBC independence. When we compare this to our in utero animals, you can see that the time to cure was a lot shorter, between 0 and 72 days, and that 2 of our animals, pig 7 and pig 10, required no NTBC treatment at all. Essentially, that means, again, that these animals were cured from a clinical standpoint of their disease at birth. All this correlated with normalization of their biochemical parameters. Their tyrosine levels were at wild-type levels by 83 days of life, and this was sustained throughout their entire lives. Same is true of liver function tests. And all of this correlated in the same way with expansion of FAH-positive cells in the liver. So we can see that shortly after birth, there are a few scattered FAH-positive cells, which are staying there in that rusty brown color. But by day 49, 50 of life, these cells had expanded to constitute about 10% of the total liver mass. By day 190, these livers were over 80% repopulated with FAH-positive cells, and by 278 days of life, they were completely 100% repopulated with FAH-positive hepatocytes. Additionally, we found no evidence of fibrosis in any of our pigs on H&E or trichrome staining. And when we looked at biodistribution in the mothers through PCR with 3 different primer pairs, we only found evidence of lentiviral integration in the uterus in 1 of the mothers. When we looked at biodistribution in the piglets, we found evidence of lentiviral vector presence only in the liver and the spleen in these animals. And we were interested in looking at the lentiviral integration profile. This is what happens in vivo in pig hepatocytes. Our lentiviral vector has a benign integration profile with preference for coding regions of the genome and no preference for CPJ-rich promoter regions or tumor-associated regions of the genome. So in conclusion, we show that in utero liver-directed lentiviral gene therapy is able to cure HT1 in the pig model, and that it does so a lot faster and more efficiently than when this therapy is performed postnatally, in some cases even without any cycling on and off NTBC. Biodistribution of the vector is limited to the fetus with little to no integration in maternal tissues, and we found no adverse events and a benign integration profile on interim analysis. Thank you, and I'll be happy to take any questions.
Questions from the audience?
Hi,
Yes.
Jessie Bresnack-Washu. That's fantastic work. Congratulations.
Thank you.
And in the one mom where you saw lentiviral integration in the uterus, were you able to look at immune response in that mom? And if you saw any kind of immune response, did you see any limitation there on that basis of integration within that fetus?
We did not look at that. It's a good idea. We had initially thought, like we did for our in vivo experiments, to look at inflammatory markers after, but since we were doing a laparotomy, that would have confounded the results.
Sure. Thanks.
As I understand it, you did direct injections into the liver, and obviously the liver is this boggy sack of blood that we all really, really worry about rupturing or damaging. My understanding is also that lentivirus targets the liver through, it's a first pass clearance type mechanism, but almost all of it goes to the liver. So did you look at other routes of delivery of the viral vector? Clearly you have very good integration, 100%, but are there other ways to do it reasonably safely, i.e. like an intraperitoneal injection or anything else?
We did not look at that. We chose this route specifically to limit integration in other areas because of safety concerns. But all our animals, we tried to limit the amount of liquid that we injected, and all our animals survived.
Thank you.
Thank you.
Our next paper will be presented by Dr. Abramoff from Columbia, entitled Comparative Outcomes of Right versus Left Congenital Diaphragmatic Hernia, a Multi-Centered Analysis. Dr. Abramoff.
Thank you and good afternoon. I'm Alexei Abramoff, and I'd like to share with you our most recent work on the comparative outcomes of right and left congenital diaphragmatic hernias. I have no disclosures to address. Let me begin by telling you a little bit about CDH, and specifically left and right CDH. Historically, right-sided lesions, which account for 15 to 25% of all CDH, were always thought to have worse clinical outcomes, a worse prognosis. Given the relative infrequency of these lesions, there is a paucity of data on the specific effect of laterality in CDH. Several recent reports have sought to compare right and left CDH, but there exists some discrepancies as well as some conflicting data. So when we looked at, for example, mortality, some authors would report that there is an increase and others would find that there's no significant difference. So we move forward with our primary research questions. What are the short and the long-term outcomes of right versus left CDH? We analyzed a multi-center database that was prospectively collected between the years of 2005 and 2019, and ultimately looked at 588 neonates with unilateral left or right-sided disease. We began to answer our primary question, focusing on prenatal, neonatal, operative, and discharge data. Here's a table summarizing our prenatal results. As you can see, the lung-to-head ratio, the antenatal imaging, as well as ECMO requirement and ECMO run were not significantly different between the two groups. Moving forward, this is a table of our operative data. We can appreciate that nearly all of our patients were operated on within about 6 to 7 days. And let me draw your attention to the fact here that our data identified that right-sided lesions were more likely to require a patch or a flap when compared to left-sided lesions. Moving forward, also, our surgeons had noted that intraoperatively, using the Lally classification system, that approximately 2/3, 63% of patients were determined to have a large C&D or higher risk lesion. Here's a table summarizing our discharge data, taking a look at it in terms of the status at 28 days, the requirement for supplemental oxygen at discharge, pulmonary hypertension, and overall mortality. Highlighting these values here, we can see that there was no significant differences here. However, right-sided patients were more likely to require oxygen at discharge. We also focused our study to look at the 2-year outcomes of neurodevelopmental data, and that was used by the Vineland test score. Here, we can appreciate that there's no significant difference between the left and the right cohorts, but also importantly that these children are performing within one standard deviation of their peers. Lastly, we performed a multivariate analysis, which proved that the supplemental oxygen in the right-sided cohort was no longer significant, and that the only significant difference was an operative repair that required a patch in the right-sided cohort. There are certain strengths and limitations to these large kinds of trials. Our core strength that we're reporting is that this trial was prospectively collected data in a multi-center over the course of 14 years. We are, however, limited by the heterogeneity of the clinical management at our participating centers. Among these interventions and outcomes, there was no significant difference between left and right-sided cohorts. However, considering the operative repair with patch and flaps, which we use as a surrogate marker for the outcome for rather a larger size hernia, as well as the intraoperative assessment, we conclude that right-sided lesions are larger. I'll take your questions at this time. Thank you.
Any questions? Dr. Abramoff, that's very interesting. A couple of things. In your slides, you had referenced outcomes such as pulmonary hypertension. Yes. If you could tell us what criteria did you use for that? How did you assess for that? And then the second question I have is with regards to this data set, are you able to give us any insight into the outcomes with regards to the technique used for repair?
Thank you for that question. In regards to the first question in pulmonary hypertension, they were given either sildenafil or nitric oxide, which qualified them, but also they had echoes at 1 and 3 months, which were centrally led by 2 cardiologists. In regards to the second question on the types of operative repair, we do have data that the vast majority of these cases were repaired with a subcostal or an abdominal approach, and along the lines of 3 to 5% were repaired with a thoracoscopic approach.
All right. Thank you.
Thanks.
All right, the next talk is entitled The Incidence of Neuropathic Pain After Intercostal Cryoablation During the NUS Procedure, to be presented by Dr. Zobel from UCSF.
Thank you very much for the opportunity to present our work. Pectus excavatum is the most common congenital chest wall anomaly, and the NUS procedure is the most common technique for operative correction. Traditional methods for managing the significant pain associated with the procedure include oral opiates, thoracic epidural, PCA, and external regional nerve block. Intraoperative intercostal nerve cryoablation is a new and effective strategy for pain control. However, there are concerns regarding its safety in pediatric patients. We recently published the results of a randomized clinical trial comparing patients who received intercostal nerve cryoablation to those receiving thoracic epidural during the NUS. We observed that those patients who received cryoablation experienced significantly decreased lengths of hospital stay and opiate requirements postoperatively compared to those who received an epidural. Following cryoablation, the intercostal nerve axon will degenerate. However, the outer neural sheath will remain intact, providing a scaffold within which the nerve axon may regenerate over the next 4 to 6 weeks. This technique has been FDA approved for use in adults for many years. However, it is not widely used among pediatric patients, and as a result, long-term complications such as the risk of neuropathic pain and persistent chest wall numbness are not well known. We had 2 primary study questions. First, does intercostal nerve cryoablation cause neuropathic pain in younger patients? And secondly, does chest wall sensation return to normal following intercostal nerve cryoablation? The ESLAN survey is a scientifically validated questionnaire designed to detect and measure the degree of neuropathic symptoms such as burning, prickling, or shock-like sensations. Importantly, numbness does not contribute to this score. Cumulative scores of greater than or equal to 12 indicate that a patient is likely experiencing pain of a predominantly neuropathic origin. 43 patients underwent cryoablation over a 3-year period at the 2 UCSF Benioff Children's Hospitals. The 2 primary outcomes of the study were the development of neuropathic pain and the duration of chest wall numbness. The SLAN survey was administered to each patient a minimum of 6 months removed from surgery, and each patient was clinically evaluated for the return of normal chest wall sensation. We divided our population into 2 groups so that we could compare adult patients to those who were younger than 21 years old. When comparing these 2 groups, there were no differences with regards to starting Howler index, gender breakdown, or the number of bars required for repair. There were, however, significant differences in particular outcome measures. First of all, younger patients experienced significantly shorter hospital lengths of stay, being discharged on an average of 2 days postoperatively. Secondly, taken together, the mean SLAN scores for the younger group was significantly lower than that of the older group. However, the average scores for neither group met criteria for neuropathic pain. And finally, 0 of 30 younger patients experienced neuropathic pain over the course of the study, whereas 23% of adults did, and this pain was refractory to gabapentin. Patients were monitored postoperatively for the return of normal chest wall sensation. As you can see here in the blue line, 29 of 30 younger patients recovered normal chest wall sensation over the course of the study, whereas only 75% of adults did. Furthermore, the mean time for return of normal sensation among younger patients was 3.4 months, whereas it was 12 months amongst the older group. So in conclusion, intercostal nerve cryoablation is not associated with the development of neuropathic pain in younger patients. We observed that chest wall sensation did reliably return to normal over the course of our study. However, older patients are at increased risk of developing neuropathic pain and experiencing delayed sensation recovery. Thank you very much for your attention. I'd welcome any questions.
Questions from the audience? While some folks are walking up to the microphone, I do have a question for you.
Please.
One, can you speculate as to why there's a difference in the return of pain, return of sensation, or relief of pain in the greater than 21 versus the less than 21 group? And then second is, are you familiar with any comparators between cryoablation and radiofrequency ablation of intercostal nerves? Certainly our pain management colleagues prefer to push the radiofrequency ablation approach, which is certainly cheaper than the $2,000 per hand unit cryoablation cost. But they claim it's better. I don't know that it is or not. Do you have any data or knowledge along those lines?
Thank you for those questions. In regards to the first question, there is actually excellent data out there that demonstrates that following peripheral nerve injuries, pediatric patients will recover and regenerate nerves at a much faster rate than adults. And it's actually been noticed that as those patients get older, that regenerative capacity decreases and the risk of complications such as neuropathic pain does increase. So I think our data may suggest that mechanism. In regards to your second question, I'm not aware of any studies that have compared radiofrequency ablation and cryoablation, so I guess I can't speak to that, although the costs of the cryoprobe are certainly something to be considered. The benefit of the intercostal cryoablation intraoperatively is the direct visualization that we have during that procedure and the ease with which our surgeons have been able to perform that technique. Yes, next question.
Yeah. Donald Nuss, Boise, Idaho. Do you have a program to follow these patients for an extended length of time, or do they just have to come back and self-report if they're having trouble?
Thank you for that question. Yeah, each of the patients within this study was followed postoperatively at regular intervals, 1 month, 3 months, 6 months, and a year. Some patients had been followed further. The range of follow-up was actually between about 7 to 10 months up to 36 months. So we were able to follow a good number of these patients. Some of the adult patients who developed neuropathic pain, 2 in particular, actually responded successfully to gabapentin. And interestingly, every patient who went on to develop neuropathic pain had symptoms at the 1 month follow-up. There were no patients who developed pain after that period that did not have pain at that point. Next question.
Yeah, Mike Gretzky, Norfolk, Virginia. Nice talk. A few questions for the adults, and again, I think that's going to be the biggest thing, is it adults versus kids? How do they regenerate? But the big question is for those adults, you operate up to 40 or 50. So for the patients who had pain, number one, were those patients, was there a subset that had pain out of proportion before the surgery? The second question is, if gabapentin didn't respond, how are those patients treated? How long are you following those? Are they yielding on the getting better, getting worse, or chronic pain?
Thank you for that question. The adult patients are obviously of concern given the risk of complication. However, there was a component of our study where we actually asked all of the patients postoperatively, based on their experience, regardless of whether they had pain or not, would they recommend this? And we found that all 43 patients had a resounding yes, given what they had heard the pain degree was postoperatively. There is a likely, a role for this moving forward in adults as well. And for those patients who did develop neuropathic pain that did not respond to gabapentin, they've been followed, and different treatment modalities have been attempted for them. Some of them report obviously varying degrees of the neuropathy, but in general, they say that the pain is manageable. And in regards to the first part of your question, we did make sure to eliminate all patients who had prior episodes of chronic pain.
We're going to have to move on with the next talk. I know there's a bunch of questions, but thank you.
Available to answer later. Thank you.
The next talk is going to be presented by Dr. Gibbons from Akron Children's, the avoidance of unnecessary bronchoscopy in children with suspected foreign body aspiration through use of CT scan. Very interesting.
I'd like to express my gratitude for the opportunity to present our work. So I'm Alexander Gibbons from Akron Children's Hospital, and I'm going to tell you why you should be using CT scans of the chest to diagnose foreign body aspiration. So toddler coming in with upper respiratory symptoms, it's almost always one of two things. Either reactive airway disease, for which surgeons aren't needed, or foreign body aspiration, which, due to the enterprising nature of this age group, surgeons are necessary. And they'll aspirate pretty much everything. But obviously not every kid coming in with coughing and wheezing has just aspirated Mr. Peanut. So the challenge for the surgeon is differentiating between the first kid, who does not need an intervention, and the second kid, who definitely does. And traditionally, what we've had to rely on have been history, physical, and plain films of the chest. But the performance for this is not that great. Algorithms that incorporate these have a sensitivity of 70% and a specificity of 60%. So pretty poor marks. And what we end up having to rely on instead is bronchoscopy for both the gold standard of diagnosis and for treatment. But the trouble is that when we're wrong, we're not wrong in a kid who's otherwise healthy. We're wrong in a kid with a reactive airway. And when we instrument that airway, it can be outright dangerous. So we can do better. At Akron Children's Hospital, we've instituted a policy wherein all patients with suspected foreign body aspiration are recommended to undergo a low-dose CT scan of the chest in order to evaluate for that diagnosis. We decided to evaluate our experience with this, and so we looked at the 3 years prior to this implementation of the protocol and the 3 years afterwards. So this was a 6-year time period. We looked at all patients who underwent either a bronchoscopy alone or a CT scan of the chest with or without bronchoscopy. Our primary outcome was the positive bronchoscopy rate, or how often we actually found something at the time of procedure. And our secondary outcome was the diagnostic properties of the CT scan and Interobserver Reliability. In order to help evaluate for those secondary outcomes, we also conducted a survey for all patients who had a negative CT scan of the chest, and we wanted to make sure that we didn't have any false negatives that we were missing. Finally, we had 3 of our staff radiologists review all imaging in order to evaluate for Interobserver Reliability. And what we found was that we had 142 patients that were evaluated for foreign body aspiration. 133 of them were included, 9 were excluded because they had an emergent presentation. And of those who we were able to include, about half underwent CT with or without bronchoscopy, and the other half underwent bronchoscopy alone. And what we found was that for those who underwent bronchoscopy alone, we had a positive bronchoscopy rate of about 61%. However, for those patients who had a CT scan that showed a foreign body beforehand, we had a positive bronchoscopy rate of 94%. So this difference was both clinically and statistically significant. Again, 61% for bronchoscopy alone, and 94% when we incorporate a CT scan beforehand. In terms of our follow-up survey, again, we wanted to make sure that we weren't missing any false negatives. So we had a median follow-up of 1.2 years. We had 44 patients eligible for the survey, of whom 34 responded. And of those 34 who responded, only 3 ultimately needed a bronchoscopy. And all 3 of those patients had no foreign body found at the time of the procedure. With this information and with what we had calculated from our chart review, we're able to determine the diagnostic accuracy of the CT scan. And you can see here that these results much more impressive than the traditional algorithm alone. Finally, we evaluated for interobserver reliability. We calculated a kappa of 0.88, which in plain English translates to almost perfect reliability. So regardless of which radiologist is reading it, we're getting consistent results. So in conclusion, use of low-dose CT scan reduces the negative bronchoscopy rate from 30% to 5%. The low-dose CT is remarkably accurate with a specificity of 98% and a sensitivity of 100%, and interobserver reliability is almost perfect. Therefore, we believe that low-dose CT scan should be used for diagnosis and bronchoscopy should be reserved for treatment. Be happy to answer any questions.
That's great. One question for you and then one for the audience. So a question for you is, how low of a dose are you using for your CAT scan? And are you using any intravenous contrast, or are you just doing non-con? And how quick does that happen?
Right. Well, thank you for those questions. I was anticipating potentially getting a question about radiation dosing. So for our radiation dosing, the overall dose-limiting product for our entire cohort was 50 milligram per centimeter. And then because this is largely a patient population of the toddler age group, we limit it to those under the age of 4. And since dose-limiting product is related to height, we have a dose-limiting product of 28. And just for reference, an abdominal CT in a toddler would be 125. So in a similar age group, we're giving 1/5 of the radiation dosing. And then in terms of your question for IV contrast, this is a non-con study. And it's also done very quickly, usually within 6 seconds. So the patient almost never needs any kind of sedation in order to get a high enough quality image in order to evaluate for a foreign body.
Okay, great. So how many people in this audience will start getting CAT scans for airway foreign bodies? Kasper? Maybe?
Maybe, yeah.
I see we have one more question there.
Hi, Ben Pandya from UCSF. I have 2 questions. How did you decide which patients would get a CT scan and which patients would go directly to bronchoscopy? And secondly, the incidence of foreign body was twice as high in the patients that had the CT scan preoperatively. It looked like there was about 60 patients in that group, and half of them were found to have a foreign body, whereas only about 1/3 of the patients were found to have a foreign body on a CT scan. So does that suggest that about half of these foreign bodies are just asymptomatic and don't need to be retrieved?
Right, thank you for the question. In terms of your first question, for the who got these CT scans, it was recommended by the radiologist after December 2015 for all patients to get it, and then at that point, it was dependent on either the emergency room physician or the surgeon of whether they got it or not. But in terms of any differences, baseline differences in terms of the 2 groups, there were no significant differences in baseline characteristics. And then in terms of why we had fewer foreign bodies found in the second arm, I'm not sure exactly. We had 49 patients who had the CT for evaluation and then didn't have any findings, but I'm not sure why exactly that was, since all of our baseline characteristics were the same.
Stephen Lee, Los Angeles. Great study. I just wanted to follow up. So who's actually ordering the CT scans? Because we find that one of the dangers of something like this is all of a sudden, like we had with appendicitis, the ER docs just started ordering all of them before we even were consulted and actually said this is a reasonable patient to order it. So is it the ED physicians? And my concern is what's going to happen if they just start ordering that as their initial study? Thank you.
Yeah, thank you for the question. Yeah, there was a mix in this study population of whether the patient got a CT before or after they were seen by the pediatric surgeon, and we would definitely recommend that they first be seen by a pediatric surgeon before committing to the CT scan.
All right, thank you.
All right, the next talk is entitled Pouchogram Prior to Ileostomy Reversal After Ileal Pouch Anal Anastomosis in Pediatric Patients. Is it useful in the setting of routine EUA? To be presented by Dr. Trainer.
Thank you for your attention and the opportunity to present. Following ileal pouch anal anastomosis, oftentimes patients are left with a diverting loop ileostomy. Six to 8 weeks following IPAA, patients are then considered for reversal of their ileostomy. And at our institution, we will perform pouchogram either the day before or the day of. Following pouchogram, patients want to go and examine under anesthesia, and then an ileostomy closure, depending on the results of those 2 prior studies. So pouchogram is a means of detecting short-term complications, such as leak in particular, but it also has been associated in adults with long-term pouch failure if found to be abnormal. And so we've typically done this prior to EUA, but there's a large number of studies that would suggest that pouchogram prior to EUA in asymptomatic patients does not aid in clinical decision-making. In particular, in adult patients, this has been reported. And so we looked closely at whether pouchogram in our institutional experience did aid in clinical decision-making at the time of planned ileostomy closure. So we reviewed 60 children over just over 11 years at our institution who underwent IPAA with diverting ileostomies. We then divided these patients into asymptomatic and symptomatic groups. All patients underwent a pouchogram prior to an EUA and closure of their ileostomy. We then looked at the results of the pouchogram study to see if it was normal, stricture, or leak, and we compared this to the findings on EUA. In total, we had 57 of the majority of patients who were asymptomatic at the time of pouchogram. There were 39 patients with normal pouchogram who also had normal findings on EUA, and one of those patients, it should be noted, did have a pelvic abscess sometime after ileostomy closure. In 10 patients who had normal pouchograms, there were 10 strictures found on EUA, and in a single patient who had a normal pouchogram, there was one stricture found, one leak found. In one patient who had a stricture seen on their pouchogram, the EUA found this to be normal, and in 6 patients there were concordant results. There were no patients who were asymptomatic who had either leak or pouch septum on their pouchogram. In total, we had 3 symptomatic patients. The first symptomatic patient underwent a pouchogram which demonstrated leak, and an EUA which confirmed these findings. The second symptomatic patient had a pouch septum and had an EUA that was concordant with the aid of pouchoscopy. And finally, in the last patient, there was a leak seen on pouchogram, which was not detectable on EUA. There was merely a stricture detected. In total, there were 8 patients with either normal findings on pouchogram, stricture, or leak, and these patients all had delay in their ileostomy reversal. We want to note that there were 4 patients who had normal pouchograms who had either clinically significant strictures or in one case an anastomotic abnormality which delayed their reversal. And finally, in the final patient who had a leak seen on pouchogram but was not readily apparent on EUA, also had a delay. Short term, following ileostomy reversal, there was 1 patient with a normal pouchogram seen here and a normal EUA who developed pelvic abscess some 2 months after. And in 1 symptomatic patient who had a leak as well as an abnormal EUA, eventually developed a pouch vaginal fistula. Looking long-term at patients with a median follow-up of 4 years, there were 4 patients who had a normal EUA and a normal pouchogram who eventually required diversion of their pouch. These patients had Crohn's disease, pouch dysfunction, and desmoid tumor in a patient with FAP. In conclusion, we find that examiner anesthesia is as good, if not better, than pouchogram in asymptomatic patients. And in fact, avoiding unnecessary radiation exposure as well as discomfort may be possible if we eliminate this as routine use in asymptomatic patients. Finally, we see a continued role for paltogram in the symptomatic patient, and our study did not seem to see that paltogram predicted long-term failures. However, this should be interpreted with caution, considering abnormal paltograms are relatively rare in the pediatric population. Thanks for your attention. I'll take any questions at this time.
Questions? Yes.
Brad Warner, St. Louis. Congratulations, that's a nice study. Can you expand on what you define as being an asymptomatic patient? Because they're diverted, so I presume that they're not symptomatic. My second question relates to how you define strictures, because many times in the operating room, before I close an ileostomy, I'll always do a digital rectal examination, and you always find a little bit of a narrowing at the anastomosis, but that doesn't require any subsequent dilations or anything. So is a stricture what you define as someone who's on a dilation program afterward, or how is that defined?
Thanks for your question, Dr. Warner. So in regards to your first question, the patients who were symptomatic, this was obviously one of the limitations of this study is that it's retrospective, but any patient who at the time of, they will typically come to clinic for us and they'll have a note at that time. And based upon the findings in the note, the patients who we defined as symptomatic, there were 2 patients with tenesmus, 1 patient with hematochezia, and another patient with just pelvic or abdominal pain. All other patients had either no findings or negative findings noted to be defined as asymptomatic. Of course, there are potentially a group of patients who are diverted and would be symptomatic had they not been diverted. However, we can't know the answer to that. And in regards to your second question, we defined stricture based upon the examiner anesthesia report at the time. So as you point out, for many of our surgeons, there will be a 2-3 finger dilation, and they'll comment on a small stricture or usual stricture. So the patients who we included with stricture were ones where the operative report dictated as the dilation being particularly difficult specifically, or where balloon dilation occurred.
Yes. Is there a question here?
The primary question I was going to ask was just answered.
All right. Thank you very much.
Thank you.
So we're going to now go to a tribute. This session is dedicated to Dr. Eric Fonkalsrud, who was APSA's 20th president and a founding member of APSA. The video was prepared by Dr. Howard Jen from Children's Hospital of LA. I'm sorry, I stand corrected, from Mattel Children's Hospital. My partner here is from Children's Hospital.
The first thing that comes to mind with Dr. Fonkalsrud is always his very bright smile. He was the most charming of people in the clinic and was always wonderful with his pediatric patients.
It is my utmost pleasure to present this video tribute to Dr. Eric Fonkalsrud. Rick excelled at an early age. After twice winning the national championship as a member of the renowned UW rowing team, he went on to attend Johns Hopkins University School of Medicine. After 2 years of general surgery residency under the direction of Dr. Alfred Blaylock at Hopkins, he completed his residency training at UCLA. Following a pediatric surgery fellowship in Columbus with Dr. Classworthy, he returned to UCLA to become its first chief of pediatric surgery in 1965.
That was when I met Dr. Fonkalsrud, who was an assistant professor and director of the lab. In those years, he was something of a forbidding presence, but over the years, I came to know Rick as a teacher and then as a colleague and a friend. Rick was the consummate academic surgeon, and I think of his model academic career as having 3 phases. The ascendancy when he was building a pediatric surgical service at UCLA and cultivating his own formidable academic credentials. Cruising altitude when he was a leader in American surgery. And then what I'll call the avuncular years as a teacher and a mentor. There was a common thread that united those phases, and it was the fierce obligation that Rick felt to create new knowledge and to take that and existing knowledge and pass it on to his students, sometimes fortified in a legendary way with soda and snacks.
One of the things I remember fondly about him was popcorn. Dr. Fonkalsrud would give small impromptu lectures in his office to the team, to the residents, and every time he would pop a bowl of popcorn and have soda for us when he would give a talk with his slides. And it was kind of like sitting in your grandpa's living room talking about talking about, the history of things. And I learned a lot about pediatric surgery, and it was those experiences with Dr. Fonkalsrud that kind of stimulated my interest in pediatric surgery.
There's so many things that you take from what Dr. Fonkalsrud did for us. In fact, I remember having popcorn in his office, and I also remember that whenever I left a research paper for him, within the next day, it was always back to me with all of his corrections. And that's something that I still aspire to do with my trainees and my research fellows, because it really was inspirational. He always kept the energy going and the enthusiasm going. He also showed us so much of his life outside of work as well. I often house sat for him and Peggy, taking care of their fish, their dogs, their jacuzzi, and it was really such a treat. He took us.
25 years ago, I was a resident on the pediatric surgery service at UCLA, where I learned from Dr. Fonkalsrud how to take care of pediatric patients. It has been said that the secret in patient care is to care for the patients, and that's exactly what I learned firsthand from Dr. Fonkalsrud. On the weekend, as I walked down the office corridor in the medical school, I will see just one office door that is consistently open, that of Dr. Fonkalsrud. He taught me what it takes to succeed. In addition to having a passion for the work, the right kind of preparation, he also takes perspiration and perseverance to succeed. What I learned from Dr. Fonkalsrud will be passed on to future generations. He represents the very essence of the adage that a teacher can never tell where his influence ends.
Fantastic. We have a couple more papers here. The next one is going to be presented by Dr. Potter from Mayo Clinic, Fertility and Sexual Function in Women Following Pediatric Ileal Pouch Anal Anastomosis.
I want to thank the program committee, Dr. Pandya and Dr. Wang, for the opportunity to present our data today. Ileal pouch anal anastomosis is the procedure of choice for children with medically refractory ulcerative colitis and familial adenomatous polyposis. There have been multiple studies that have demonstrated excellent functional outcome and improved quality of life in these children, and many have been published by Dr. Fonkalsrud, who we just heard about. Yet there's little data regarding sexual function in these ladies following ileal pouch anal anastomosis. Our goal was to report our findings in long-term follow-up. We queried a prospectively maintained colon and rectal database of all patients that underwent ileal pouch anal anastomosis at Mayo Clinic Rochester from January 1980 to October 2015. We included all women that returned at least one survey between the ages of 20 and 45 years and who had undergone ileal pouch anal anastomosis prior to 20 years of age. We identified 200 ladies that returned to survey within the study period, of which 149 females or women reported or answered the sexual portion of the questionnaire. 93 of these ladies had reported either becoming pregnant or attempting pregnancy. The age at ileopouch anal anastomosis was the same across the three groups, as were the indication for operation. Painful intercourse was reported in 30% of our patients, and this was similar across the three groups. And severely restricted sex life was reported in 4 to 6% of ladies that had undergone pediatric IPAA. While there was no information on the survey regarding what was the cause of the severely restricted sex life, upon chart review, all of these women had pouch complications such as fistula or chronic pouchitis, or severe medical comorbidities such as liver transplantation secondary to primary sclerosing cholangitis. Of the 93 women that reported attempting pregnancy during the study period, 73% were able to become pregnant. 1 in 5 required medical assistance, including one couple that required assistance with dysfunctional sperm. 58 women delivered 62 babies. There were 10 reported miscarriages and 2 elective terminations. Cesarean sections were used for delivery in 55% of our patients, of which 27 were planned by the obstetrician. Pouch function changed in 45% of patients during their pregnancy, and this change and decreased function persisted in 32% after pregnancy. There was no increased incontinence reported following pregnancy. We did examine factors that have been reported for reduced fertility in adult women following IPAA. We did not identify any associated factors for reduced fertility following pediatric IPAA. This is most likely because of the small number of events that occurred in our model. Interestingly, all 7 women that desired pregnancy that had undergone a totally laparoscopic proctolectomy were able to become pregnant within the study period. So in conclusion, we identified a 73% fertility rate in women following a pediatric IPAA. 88% of these ladies were able to deliver a healthy baby. 5% reported a severely restricted sex life, and this seems to be associated with pouch complications and severe medical comorbidities. 30% reported changes in pouch function after pregnancy. However, there was no increase in stool incontinence. And while this requires further study, minimally invasive proctolectomy appears to be associated with improved fertility in young ladies that require ileopouch anal anastomosis. Thank you.
That was great work, Dr. Potter. I had a couple of questions. Could you tell us more about the change in pouch function and how you assessed for that and what you found? And then the other thing, I was a little surprised that only 7 patients had laparoscopic proctectomies. Could you tell me a little bit more about that too?
Yeah, so regarding change in pouch function, it was almost universal that they had an increase in stool daily bowel movements, including nighttime bowel movements. And we have adult data that would suggest that that bowel function returns to normal. We found that actually about a third of patients that didn't come back to their pre-pregnancy stool function. So in general, it's just an increase in output, including day and nighttime stooling, without an increase in pad use and incontinence. I can't comment on any sort of medications that they may have been using. That was not in the survey. And then, the laparoscopic proctectomy is something that's relatively new. It started probably about in 2009, and still some of our partners continue to do an assisted proctectomy. So a lap-assisted technique is still most common at Mayo Clinic.
Right.
So the numbers aren't quite there yet.
Okay. We have 2 questions. We have a question there. I can't see.
Hi, Scott Short from Salt Lake City. I was wondering if you could comment on whether there were changes in fertility with regard to epic or medication, epic of time or medication exposure in addition to technique. And secondly, do you send these young women for counseling with OB preoperatively? I know some of our local surgeons have, for instance, been delaying creation of a J pouch in women in their 20s until they've completed childbirth due to concerns. Thank you.
So upon chart review, it appeared that the most common reason for infertility was obstructed fallopian tubes. Although there were some, inadequate follicle formation for which medications were used, and of course the one couple that had artificial insemination due to male factors. The rate of fertility would still be 100%, but it would require some sort of assisted fertilization, and that study has been performed several times in the Scandinavian countries. Regarding delaying surgery for family planning, most of our patients really can't wait to consider that. I certainly talk to them about family planning, and if they're very interested, then really the procedure of choice would be a total abdominal colectomy with endoileostomy. However, there aren't many patients that want to stay with that situation for as long as they have to. So in my opinion, these days, using a totally laparoscopic, minimally invasive technique, I always look at the ovaries and fallopian tubes to make sure they're not stuck down into that area where you open the peritoneum. I think the fertility rate will be quite high.
I think we have reached the limit of our time. So
okay, thank you
very much.
All right, the final presentation for our session this afternoon is transanal minimally invasive completion proctectomy with iliopouch, anal anastomosis, and ulcerative colitis, to be presented by Dr. Short.
Hi, thank you for the opportunity to present our work. And let's see.
The first report of the transanal proctectomy for patients with ulcerative colitis was published in the Journal of Colorectal Diseases in 2016. One of the stated benefits of this procedure is that by using a perineal port, you are able to precisely control the length of the rectal cup. Here we report, to our knowledge, the first case of the use of this technique in a pediatric patient. Our patient is a 13-year-old girl with medically refractory ulcerative colitis. She presented with persistent rectal bleeding and abdominal pain and was taken to the operating room for a 2-stage proctocolectomy with iliopouch anal anastomosis. A laparoscopic proctocolectomy is performed by first identifying the left ureter, and then taking the mesentery of the left colon, the transverse mesocolon, and ultimately the right colon, which is performed in an antegrade fashion after identifying and preserving the right ureter. After completing the mesenteric dissection of the colon, after completing ligation of the mesocolon, the mesorectum was divided down to the level of the levator ani. The right lower quadrant port site is then enlarged to accommodate the specimen extraction. This has been placed in the location for the subsequent diverting ileostomy. After the specimen is extracted, the terminal ileum is divided. A J pouch is created with the goal of a pouch length of approximately 15 to 20 centimeters. This is performed in a standard stapled fashion. After this, the anvil of a 28 millimeter EEA stapler is placed at the apex of the J pouch. A red rubber catheter is secured to the anvil to be used for subsequent perineal extraction after the perineal dissection. The J pouch is then returned to the peritoneal cavity, and the 12 millimeter port is secured once again into this location with a towel clamp. The surgical team then turns their attention to the perineal dissection. A Lone Star retractor is placed at the level of the dentate line, and a purse string suture is placed approximately 4 centimeters proximal to the dentate. After placing the purse string, a circumferential transmural incision is made with electrocautery just distal to the purse string suture. The perineal port is then placed and the rectum is insufflated. The gel port with 3 5mm trocars already inserted allows insertion of a camera and 2 working instruments. The rectal dissection is then carried out in a distal to proximal fashion along the wall of the rectum. The purse string is grasped and the perirectal plane is dissected with the combination of electrocautery and ligature dissection. This dissection is carried proximally again to the level of the levators, and the plane with the former intraperitoneal dissection is reached. The rectal specimen is completely freed from perirectal connective tissue. The completion proctectomy specimen is then retrieved from the perineal port site and passed from the field. After re-insufflating from the perineum, the red rubber catheter is grasped and the J pouch is pulled down to the perineal field. A purse string is then performed in a transmural fashion at the level of the prior rectal transection. The EEA anvil is then grasped with a right angle, and the purse string is tied after removing the red rubber catheter. The anastomosis is then completed from the perineal perspective with the EEA stapler. This allows the precise control and creation of a rectal cuff of approximately 2 centimeters in length proximal to the dentate line. The operation is then completed with rigid proctoscopy with an air leak test. This patient is currently doing well, awaiting her second stage ileostomy takedown.
All right. Thank you. Any questions from the audience?
Dean Potter, Mayo Clinic. Thanks for the excellent video. What sort of insufflation pressure do you use while you're doing your proctectomy?
We've been just using 15 millimeters of pressure like we do when we do laparoscopy, and it's actually quite nice because it really exposes the plane and really helps with the exposure.
Yeah, it's excellent. One tip I do have for you, if you take that red rubber and suture it to the top of your rectum, when you pull your rectum out, the pouch just comes with it. So that's what we've been doing for a while. It works really well.
Okay. Thank you.
Hi, Kurt Heiss from Atlanta. Boy, that was a really fascinating use of a port system. So I want to compliment your innovation. I was curious if you'd considered using a single site approach to doing the colectomy, because if you mobilize the right and left colon, you can do all your dissection extracorporeally. And then you had it faced that person's perineum so much, it almost seems like you could have everted the rectum after having measured it properly and done your stapling in an extracorporeal fashion, and then pulled your J pouch down and stapled it much as the way you. Nice video.
All right, thank you.
Hi, Jason Fisher, Cincinnati. Great presentation. One of the things that I've been noticing in the adult literature is the cuffitis, which is a new entity, I think, in our J-pouch patients from the double staple technique. And so this is a great demonstration of how we might be able to avoid that. I've also used this port system for stercal ulcers and some polyps that I've had to get that are a little higher up. So this is just an excellent presentation and wanted to congratulate you.
Thank you.
All right, thank you so much.
So